Hello, my name is Isabella, and for the Talaria Summer Institute report, I decided to do resilience and resistance against Alzheimer's disease, and my mentor was also Krista. So, starting off, what Alzheimer's disease is. Alzheimer's disease is actually one of the most common causes of dementia, accounting for more than 2/3 of all cases. And it can cause symptoms such as memory difficulties, sudden mood changes, and sudden behavior changes. When people come in to be diagnosed or evaluated on their cognitive state, there are often three levels that doctors can provide, which is healthy, which is your normal aging process, mild cognitive impairment, MCI, which is the level between healthy and dementia or Alzheimer's, and then Alzheimer's disease. It's also important to note that not all mild cognitive impairment patients descend into AD and can actually sometimes see recovery. So that's why it's its own separate diagnosis level. There are also risks that can increase your possible development of Alzheimer's. There's genetic, lifestyle, and behavior. And for our project, we investigated the apolipoprotein E-ApoE, which is a genetic risk. So ApoE, or apolipoprotein, is a type of protein that is responsible for creating lipoproteins, which actually carries cholesterol through your blood. And there's three types: E2, which is actually a protective measure against Alzheimer's, E3, and then E4 is the risk allele that we decided to investigate. We use two pathologies, white matter lesions and hippocampal atrophies. Both are common and hallmark signs of cognitive decline and Alzheimer's disease. So we can actually see Alzheimer's disease physically manifesting in MRI scans. So the red arrows point to a healthy hippocampal volume, and the Alzheimer's patients represent hippocampal atrophy that is commonly seen in Alzheimer's patients. We can also see it with white matter lesions or white matter hyperintensities. These are areas with abnormal myelination in the white matter, and on MRIs, they can actually be like bright white spots. The reason behind white matter lesions is thought to be chronic lack of blood supply to the brain and can actually be a representation of cerebral vascular dysfunction. So the top scans are the baseline, and then the bottom scans are when the patients returned, and the arrows represent to increased sections of white matter lesions in the brain. So for our research question, we were more interested in how the rates of hippocampal atrophy and white matter lesion accumulation over time differed by genetic risk, cognitive status, and by sex. We were able to utilize the ADNI database. We made sure to filter out and make sure that we had the full scale of information, such as the scans, the cognitive tests, and full medical history. This came out with a sample size of 336 individuals, 152 male, 184 males, and they all ranged from 55 years old to 97 years old. ADNI also categorizes them by conversion status or cognitive groups. This is what most of our project is based off of. We utilized the preprocessed imaging data and calculated the annual rates of change with this equation. The N represents number of time points in the data set, which just says how many times they decided to come in. The measure is either hippocampal volume normalized to total intracranial volume or log transformed white matter lesion volume. And then T just represents time or age. Because our main interest was in the rates of change rather than the amount, we wanted to investigate how the trajectory impacted conversion status and decided that average annual rate of change would be the best way, since it would demonstrate that if there was a steeper trajectory or steeper decline. We used statistical testing. So we used ANOVA, or analysis of variance testing, and GLM, or generalized linear model testing. ANOVA is comparing groups against each other. So this is often many groups, while GLM is more specified, which is how does one group differ from these other groups. Here's a visual representation, just so it's easier to kind of understand. So for our results, we first used visualizations in order to narrow down our statistical testing. So here are some examples of graphs that I made in RStudio. The one on the left is hippocampal volume over time. The y-axis is normalized hippocampal volume, and then the x-axis is age. Our legend, I included healthy to MCI, MCI to AD, always healthy, and always AD just as a time point for this graph. The same is for the white matter lesion graph, which on the y-axis is log white matter hyperintensity volume, and then the x is age. We can see on the visualization for the hippocampal volume that cognitive decline, so healthy to MCI, always AD, and MCI to AD, was often associated with lower volumes of hippocampal rates, and cognitive decline groups often saw higher white matter lesion rates. So we first conducted an ANOVA test. This ANOVA test compares all cognitive groups against each other based on an average annual hippocampal volume rate of change. The top numbers, the ones that aren't highlighted, are the p-values. The bolded ones are statistically significant, meaning that they were less than 0.005. And then the bottom are the differences in hippocampal annual average rate of change. It just means that the row, if the difference was negative, it just meant that the row was smaller than the column. And the same is with this ANOVA test, which is actually average annual white matter lesion rate of change. Surprisingly, there was no observable statistical significance in the ANOVA test regarding white matter lesion rates, which I'll discuss later. And then we also used generalized linear model testing just for a more specified kind of testing. We found that the most statistically significant groups were always healthy patients versus always AD and MCI to AD patients, and were statistically significant in both white matter lesions and hippocampal volume rates of change. Always healthy patients were statistically significant against always MCI in only white matter lesion rates of change. We also saw that always AD patients were statistically significant from always healthy and healthy to MCI in both white matter lesion rates and hippocampal volume rates. And then always AD versus always MCI were statistically significant in only the ANOVA testing, which I'll also get into later. And then regarding our APOE testing, we saw that there was a statistically significant change in annual average rate of change in hippocampal volume. However, there was no observable statistical significance in white matter lesion rates. This suggests that the E4 risk allele may be associated higher with steeper rates of hippocampal volume loss. And then for our sex effects, we used the ANOVA testing, and there was actually no observable statistical significance of sex differences or in any interaction effects, either in both pathologies that we used. So for our discussion, we realized that always healthy patients differed most from patients that normally descended into AD. They were also different from always MCI patients, but only in white matter lesion volumes. We suspect this is because there's been a multitude of studies in the Alzheimer's community that white matter lesions is actually closely connected more with mild cognitive impairment compared to AD. Then the always AD patients were the difference was surprising because while they were different from always healthy, they also differed from healthy to MCI and always MCI patients. It was unexpected to see this just because of our assumption that because both groups were cognitive declines, that we wouldn't see any statistical significance. We also didn't see any sex differences either. This is because we decided to test sex because of the possible menopausal and estrogen decline rates that we researched. However, we assumed that we didn't see any sex differences due to the fact that our ADNI database was targeted more towards the elderly who were already out of postmenopausal stages. And then our findings suggest that ApoE4 risk is more associated with steeper rates of hippocampal volume loss, but not with white matter lesion volumes in statistics tests. Our conclusions is that individuals who resist Alzheimer's disease may be able to do so by slowing hippocampal volume loss. This is just because we see patients with always healthy or who didn't descend into AD with higher hippocampal volumes. And possible future directions may include further evaluation of sex differences and evaluating the difference in location versus rates in white matter lesions in the brains across ApoE genotypes and cognitive groups. So this is all the resources I used for this slides. And I'd just like to thank Talaria for this wonderful experience and opportunity, for Adney for sharing their data, and for my mentor, who was really open, patient, and kind during this project. And that is the